When you have no data, it's very difficult to discuss with the patient to have the trend between toxicities and efficacy. Up to now, we had zero data, so it's very, very important. Everyone was waiting for that, because it's been a long time that we know now that 10 years of tamoxifen is somehow better than 5 years. And everybody's, when they finish their 5 years of aromatase inhibitor, doesn't know if you have to go on or stop. And we did not have any data on that. The data are positive, and it's nice. There's 4% improvement in PFS. But it's 5 more years of aromatase inhibitors. And when we look at the details, the most important improvement is in decreasing the contralateral breast cancer. So it's like a preventive therapy that prevents second cancer. But when you look at the metastatic disease by itself, there's only 1% improvement with 5 more years of aromatase inhibitors. And there is no activity at all on overall survival. It's practice changing in a way that you can have a more rational approach to prolonged hormone therapy. I don't think there will be a lot of patients that will have 10 years, because it's quite challenging and very few of them will benefit. But that's sure that some patients will benefit if they have a high number of lymph nodes involved and so on. And I think it's very important to be able to have data to discuss with the patients and to make shared decision making to know if we can go on with hormone therapy or not. It's a very interesting study because it's the only one that uses the CDK inhibitors of the monotherapy. All the other ones were done with combination with hormonal treatment. And the results are pretty impressive for such a drug, with a 20% response rate, 6 months PFS for patients that have already received previous treatment. So that's what you can expect from chemotherapy, in fact. Those patients did not receive any CDK inhibitors before. So one we can think, if the abemaciclib was alone in the field, it would be nice. You say, you can use it as a monotherapy in multiple lines, and you will still have some good results. But right now, with the new results that are going out with first line and second line CDK inhibitors with hormone therapy, all patients will have received CDK inhibitors before. So we don't know at all how those results could apply to the future patients. So we don't really know what to do with those results. I think the next step will be to test this drug in combination with hormone therapy or without, after failure of previous CDK inhibitors. Anyway, it will be the only way to test it, because the two other ones, abemaciclib and palbociclib, will be approved in first and second line very rapidly now. So abemaciclib could be used after them, and so they have to show if you still have some interest in combination with hormone therapy or alone after failure from a previous CDK inhibitor. I guess it's the best way to go.